may be elevated, but T3, free T3, TSH is normal. Okay. In familiar dysalbuminemic hyperthyroxanemia, only T4 and free T4 is elevated. T3, free T3, TSH is normal. Okay.
T3 is normal?
T3 is normal. And this is the difference between pregnancy or heparin. Heparin affects only free thyroid hormone.
Yes.
Heparin affects only free T4 is elevated, free T3 is elevated, but total hormones is normal. TSH is normal in heparin.
Thank you, Dr. Khaled.
These 2 points from yesterday questions. Let's go to the first question today. 35 years old lady presents with 1.5 centimeter nodule in her thyroid. 5 needle aspiration biopsy results shows type 2 lesion. What should be the most appropriate step in the management? Type 2. Lobectomy or reassurance and discharge, radioiodine ablation, refer to total thyroidectomy, repeat 5 needle aspiration biopsy in 3 to 6 months. Let's hear the
according to RCB, repeat 5 needle. No. To make sure it's benign. So to make sure it's benign, you should repeat it, I think.
I think reassure and discharge.
In RCB, you should repeat, but in American, you should discharge. It's benign.
Okay, this is the area of conflict between American Thyroid Association and NICE recommendation. Of course, in NICE, when Cy2 lesion is the result, so we must repeat 5 needle aspiration biopsy in 3 to 6 months to be recorded as a benign lesion. In American, once it is Cy2, so it is reassurance and discharge. So if it is a question in our exams, so we must repeat. Okay. This is according to British Thyroid Association guidelines published 2014. Is there any comment? Please, if anyone has a comment on the question or answers, please let me know.
It's okay, doctor. Let's continue.
If 5 needle or ultrasonographic pattern U2, so it is a benign lesion. So reassurance and discharge U2.
Yeah. Yes.
Okay. The next question from.
Sorry. Just about the previous questions. Is the size indicate any things here about 1.5 centimeter? If the size is big, is smaller, less than 1 centimeter, do we need also to repeat it in 3 to 6 months' time, if it is type 2?
Once it is classified as type 2, so it needed to be a benign lesion, to be labeled as a benign lesion.
I think size has no matter in the previous question because 5 needle already done.
Okay, of course, yes. Of course, yes. Once 5 needle is done, so we look for the size classification. The next one, if anyone wants to read that.
I can't read exactly because it's very small for me.
I can read. Which statement on thyroid cancer is true based on recently published epidemiologic studies? A, increase incidence, stable mortality. B, increase incidence, increase mortality. C, stable incidence, increase mortality. D, increase incidence, decrease mortality. And E, decrease incidence, stable mortality.
What is your opinion?
I think A, increase incidence, stable mortality.
Another option?
I don't understand the question.
What about epidemiological studies stated about thyroid cancer? Is the incidence of thyroid cancer increased or stable or decreased? What about mortality of thyroid cancer?
Yes, it is increased.
I think
Yes,
increased.
it is increased incidence but stable mortality.
Yes, I think this is.
And I think so, but the results is the right answer is different. Right answer: increase incidence and increase mortality. Increase mortality. And we must mention that with aging, the incidence of thyroid cancer is low, but aggressiveness of thyroid cancer is high.
Dr. Khalid, this is incompatible with the.
Yes.
In the last National Institute of Health in the United States, they mentioned that the incidence is increased with a stable mortality. I don't know what about British guidelines or British epidemiologic studies.
Really, this question from ACE endocrine review course accomplished in Dubai.
They put reference. What is the reference, Dr. Khalid? I can't read.
National Review Endocrinology. National Review Endocrinology. Study published 2016.
Okay.
Thyroid follicle cells synthesize thyroglobulin, which is compromised of triacid residue, carbohydrate, and iodide. This is the first part of question, but the question: which one of the following conditions associated with decreased TG level? Graves or hyperthyroidism, subacute thyroiditis, factitia, or untreated differentiated thyroid?
Factitia.
Factitia, of course. Factitia, mainly TG is low. Question about screening. 18-year-old girl was started with on methimazole for a new onset Graves' disease. Considering risk of granulocytosis caused by methimazole, which follow-up plan is recommended for this patient? What does we mean by a granulocytosis?
What's the question?
What does we mean by granulocytosis? Granulocytosis.
Granulocytosis, I think, is neutrophils less than 1,500.
1,005 or lower than this number?
Lower.
I think less than 500.
And severe if less than 500.
500. The granulocytosis as a side effects of antithyroid drug means less than 500. Caused by methimazole, which follow-up plan is recommended?
CBC with differential if she develops sore throat and fever.
C or D? Sore throat and fever, or sore throat or fever? Or routinely to do CBC with differential?
D.
I think it's D.
D.
Yeah, I would go with D.
With D, of course it is with D. Any sore throat or fever, we must stop antithyroid drug until to do CBC and with differential cap.
I have a question here.
Yes.
If we have sore throat, we should discontinue until CBC, or to continue, or what?
Stop.
Yani if she has sore throat today, the patient, okay, and at the morning she didn't take her methimazole, she should not take.
We must stop antithyroid drug,
even sore throat only.
Okay.
But after CBC, it's normal.
After CBC, continue the treatment if it is normal,
okay.
Or if a granulocyte more than 500. So the routine CBC monthly or any other lab for a patient with antithyroid drug is not done routinely. What about this case? A 32-year-old woman was admitted to the medical assessment unit with nausea, vomiting, dehydration. She also complained of intermittent headache and visual impairing. 34 is high, mildly higher than normal, 54 mildly higher than normal, 21.3. TSH is normal, 4.1. What one of the following tests may be useful to diagnose TSH tumor? TSH secreting pituitary tumor. 3 millimeter lesion in the pituitary MRI, blunted or absent response to TRH stimulation, decrease alpha subunit TSH molar ratio, or low to normal level of 6 hormone binding globulin, negative gene sequence for TH or beta gene.
Option B, that is blunted or absent response to TRH stimulation.
So how to differentiate between TSH secreting pituitary tumor and thyroid hormone resistance syndrome?
Stimulation with TRH and
By
TRH
alpha
subunit and TSH molar ratio. If ratio is more than 1,
so it is
considered a TSH tumor.
Of course, the first one by alpha subunit to TSH ratio. If it is high, so it is TSH secreting pituitary tumor. If it is low, so it is TSH secreting pituitary tumor. Another parameter to differentiate between them, response to TRH. In TSH secreting pituitary tumor, blunted or absent response, but in TSH secreting pituitary tumor, response will be in thyroid hormone resistance. If we done TRH stimulation, the response will be what? TSH will be elevated. TSH will be elevated. Okay. What about 6 hormone binding globulin in both conditions?
In TSH tumor, CHPG will be high.
Of course, 6 hormone binding globulins increase in TSH tumor. What about طبعا genetic testing will be positive in TSH thyroid hormone resistance syndrome? What about pituitary MRI?
Incidentaloma is common.
Of course. So 3 millimeter lesion in the pituitary MRI cannot exclude the thyroid hormone resistance syndrome because it may be pituitary incidentaloma. Most of TSH secreting pituitary tumor is microadenoma, less than 1 centimeter. So the best answer is blunted or absent response to TRH.
Just a question here about the ratio. It is more than 5.7?
Once this is most of examination will be mentioned no number about it, but in the Oxford Handbook endocrinology and diabetes mentions it is must be more than 5. 5 or 7? I think it is 5.
I think it's 5.7.
It is increased. We can no number here, but mostly it is increased. 65%, elevated in 65%. Okay. Another one. Anyone to read?
Anyone to read, please?
A 27-year-old woman presented to her GP with an anxiety, palpitations, and increased sweating. She was 8 weeks postpartum and not on any medications. On examination, she had bilateral tremors and pulse rate of 96 beats per minute with no eye signs or grave disease or goiter. Thyroid function results, free T4 on the upper limit of normal, 22.5 picomole per liter. TSH suppressed less than 0.18. TSH receptor antibodies negative. Which one of the following is the most appropriate management?
What is the diagnosis first? What is the diagnosis first?
Peripartum thyroiditis. Postpartum thyroiditis.
Postpartum thyroiditis. Why postpartum thyroiditis? Why not Graves?
Because TSH receptor antibodies negative.
Of course, which is present in about how much percent TSH receptor antibody in Graves' disease?
More than 90%, 95.
95 to 100%.
Yes.
So once it is negative, so it exclude grave disease. So it is postpartum thyroiditis. In which stage of postpartum thyroiditis? Thyrotoxic stage. Thyrotoxicosis. Thyrotoxic stage present about 2 to 3 months after delivery. What is the treatment? Appropriate management approach in her case.
Propranolol, because she is tachycardic.
Tachycardia. So
Propranolol.
with the propranolol. If heart rate is lower than this, normal heart rate.
No, non-steroidal anti-inflammatory. No, sorry. Sorry.
Non-steroidal
to do.
is the equivalent thyroiditis.
Yes,
Just observe.
Just observe. So carbimazole is not an option here, or provides or a radioactive subtotal, just propranolol. So it is postpartum thyroiditis. Another question. 74-year-old old with past medical history of life-threatening arrhythmia is on long-term amiodarone therapy and fitted with a defibrillator 2 years ago. He has been clinically asymptomatic for the last 1 year as far as symptoms of palpitation are concerned. His recent routine blood test shows TSH is high, 34, 4.6, lower than normal. Anti-TPO is negative. What is the next therapeutic intervention? What is the diagnosis here?
Amiodarone-induced hypothyroidism.
Is it subclinical hypothyroidism or overt hypothyroidism?
No, it is overt hypothyroidism.
Of course, it is overt because 34 is lower than
It's low. We should start low dose thyroxine because he's elderly with arrhythmia. So we have to start thyroxine 25 microgram per day.
What is the next therapeutic intervention? Liothyronine, which is T3, or radioiodine ablation, or thyroxine 25, or thyroxine 50 microgram, or stop amiodarone.
I think we can stop.
In life-threatening arrhythmia,
We can give other treatment or not.
in the first, stop amiodarone or not?
I wouldn't stop amiodarone. It's a life-threatening arrhythmia, I think.
Of course.
Go for a small dose of thyroxine.
And the recommendation guidelines recommend that in amiodarone-induced hypothyroidism, amiodarone can be continued. What is the treatment? It is thyroxine. What is the dosage of thyroxine in our case?
25.
25 or 50? 50?
No, 25. 25.
5.
Of course, it is one. Of course,
I have a question about guidelines. One guy about hypo or hyper to stop. One of them to stop and one can to stop.
In hypothyroidism, thyroxine can be continued.
No, I am talking about amiodarone.
Amiodarone can be continued.
In hyper, we should discontinue.
In hyper, according to type 1 or type 2, even in type 2 or type 1 or type 2 amiodarone-induced thyrotoxicosis, if it is life-threatening arrhythmia, so don't stop amiodarone. But
in hypo,
if can stop, in hypo, amiodarone can be continued. Start thyroxine by low dose thyroxine 25.
Yeah.
If you want to put the guidelines of amiodarone here, keep the guidelines. Rapidly, I will. This is the algorithm for amiodarone-induced hypothyroidism. European one.
Arrested program, Dr. First.
Amiodarone-induced hypothyroidism, chronic autoimmune thyroiditis, so we must treat by levothyroxine. Normal thyroid, can amiodarone be withdrawn? If it is no, so treat. If it is yes, stop. Stop amiodarone for and reassess after 1 or 2 months. If euthyroid, so follow up, no treatment. If hypothyroidism, levothyroxine replace.
So I think in hypo we can stop. If
We can
in
stop if it is visible, but
Right.
if you review guidelines and another recommendation, you will.
there is guidelines for hyper.
نعم.
Hyper.
This is the hyper
Yes.
algorithm for hyper. In amiodarone-induced thyrotoxicosis type 1 or type 2, stop amiodarone if feasible. In amiodarone-induced thyrotoxicosis type 2, amiodarone can be continued. Okay.
Thank you. It's very nice. So amiodarone type 2 should be continued.
Not should.
Right.
If it can be stopped, so stop it. Amiodarone have life is very long, so if we stop it nowadays, it will be continued for a lot of months. Another question from the book Best of 5. If anyone wants to read it.
Anyone can read the question, please?
This is the case, and the question is not related to the case. So we can go to the question, which one of the following is associated with normal increased uptake on radioactive iodine scale? In amiodarone-induced thyroiditis, factitious ingestion of thyroid hormone, subacute thyroiditis, trauma over eye, trophoblastic disease, which of the following is associated with normal increased uptake on radioactive iodine? What about amiodarone-induced thyroiditis? What is about uptake? Is it normal or high or low?
Low.
In type 2, it's low. In type 1,
1,
mostly low, but sometimes it increased or high.
Or no, or normal, of course.
Yes. In technician,
normal,
better.
Of course. In type 2 amiodarone-induced thyroiditis, it
Low.
be low or 0. What about factitious?
Factitious.
No.
Factitious, it is also low.
Low uptake. Subacute thyroiditis?
0.
Trauma over eye?
Low.
Low in the thyroid region, but in the ovary uptake is high. Trophoblastic disease?
I think this is the
The right answer.
Also low.
Normal or high. لا, trophoblastic disease, it may be normal or high. Okay. يبقى thyroid uptake is normal or high in Graves' disease, toxic nodule, trophoblastic disease, TSH secreting pituitary tumor, high uptake, resistance to thyroid hormone, normal or high uptake. Oh. That's okay. Next one. Dr. Mahmoud Izzat.
I can, just a minute. 43-year-old woman was reviewed in the thyroid clinic at a follow-up appointment 2 months after she had undergone radioactive iodine therapy treatment for recurrent Graves' disease. She complained of non-specific symptoms, including lethargy and lack of appetite. On examination, her heart rate was 80 with no signs of thyroid eye disease. Thyroid function test, free T4 is 22.5, high. 3T3, 6.2, it's high normal. TSH is decreased to 0.05. Which one of the following is the most appropriate approach at this stage?
I would go for E.
For E, repeat thyroid function. Why E?
Because it's just recent that the radioactive thyroid will take up to 6 months.
Yes, of course. Why not to give carbimazole in this case?
I think it's just because it's very recent. The radioactive
Even in very recent after radioactive iodine, in the most cases we prescribe antithyroid drug.
Yeah.
If the patient is symptomatic, if the free thyroid hormone is
Yeah.
very high, so we can give anti-thyroid drug and tapering it according to thyroid function test. But in our case,
or we
thyroid
can
function
give
is
beta
mildly
blockers.
elevated, or beta blocker if tachycardia or tremor, of course. Here, free thyroid hormone is mildly elevated if free T4, if free T3 normal. ESH is suppressed and takes a lot of time to be recovery. Hypothalamic pituitary suppression will take a lot of time to be recovered. So we follow up Graves' disease by free thyroid hormone until recovery of pituitary hypothalamic pituitary axis. The patient, most of symptoms complaining if non-specific symptoms, lethargy, lack of appetite, all of them are non-specific to thyrotoxicosis. So we must repeat thyroid function test after a few weeks. Another important point about radioactive iodine and resistance to radioactive iodine. What is the drugs that make the patient more resistant to radioactive iodine ablation? Which